Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being with us today, October 10th, 2019, for our North Carolina Community College System Lecture Series. And today's topic is caring for the patient with breast cancer. Of course, this is Breast Cancer Awareness Month, and so this lines up very well with all of the different activities that are going on around Breast Cancer Awareness Month this October and every October. A few things before we get started. If you're having any technical difficulties at all, please let us know right now. We do have technical staff standing by 919-445-1000. You can also email us at unccn@unc.edu. We have a host of materials available online at unccn.org. Many of you will be viewing this lecture not as a live lecture, but after it's been recorded, and you can go to our site and find out about how to receive credit for this lecture through our learning portal, and many of you, I imagine, will be getting certificates of participation, whether this is an assignment with your class or whether this is being used for extra credit, etc. So all of that is available, and you can always call us 919-445-1000 if you have any questions. So a few preliminaries. We do also we have a whole professional series of lectures with free continuing education credits at unccn.org. We've got details about that. We're also on YouTube, and we have a media site learning library with over 200 different oncology videos there. So lots of other information. We really rely on each and every one of you to fill out an evaluation. Let us know how we did with this presentation today. So please, if you're watching this live, before you leave the classroom or wherever you are, go to unccn.org/eval. That's unccn.org/eval and fill out an evaluation. We really appreciate that. I want to say that in advance. All right, this is an interactive lecture, and what that means is that we would love for you to participate. We'll be asking some questions, and when I say we, all of the great presenters we have here today will be asking questions of you. These are all anonymous, so you can answer these in one of two ways. You can go to polev.com, that's polev.com/UNCCN. You can do that on a smartphone, you can do that on a tablet, you can do that on a laptop, on a desktop computer. But please do that now, and then as the questions are provided, you'll be able to answer those, and then at the end you'll be able to share your questions with the presenters. So please be jotting down your questions as we go through the presentation today, and then asking those questions at the end of the presentation. You may also use the texting function on a phone if you prefer. Right now, if you would go ahead and in the to field, type in 22333, and in the message field, type in UNCCN. You do that one time, you send that, you'll get a little response back saying that you've joined, and then you can go ahead and text the letters that correspond with the answers to us. You'll see those live as they pop up in our poll, and then at the end you'll be able to share your questions with our presenters. Our question, I think this is kind of a softball, but this is: which of the following is the most common form of cancer in North Carolina? And we'll be showing the actual poll. This is just a screenshot right now. But which of the following is the most common form of cancer in North Carolina? If you think that's A, lung and bronchus, B, breast, C, colorectum, or D, prostate, you can put in the corresponding letter, and then we'll find out what the answer to that is. All right, so without further ado, caring for the patient with breast cancer, and we have with us first Amy Depew. So Amy, welcome. Thank you so much for being with us today.
Thank you for having us.
Absolutely. So let's see, we've got a bio for you, and then we'll come back to our poll. So you've been working with breast cancer patients since 2004. And lived and worked in Chapel Hill since 2009.
Correct.
And currently working with medical oncology in the breast cancer division. Mm-hmm. And passionate about your three dogs, Arlo, Levi, and Max, two golden retrievers, and a very spunky golden retriever wannabe.
That is correct, and I think they are listening to us today.
Well, good. And let's see. Let's take a look at that poll and see how we're doing here. And we'll take a few more seconds to let our audience go ahead and respond to this. Thank you so much for all of you who are responding. Again, this is anonymous, so give it a shot. See how you did. And we have lung and bronchus at about 25%, breast at about 78%. How are they doing?
I think they're all doing really well.
Great.
And I think the thing to point out is remembering that this is in North Carolina, so those numbers would be different otherwise, but yes, congratulations.
Good. And I had to think about this for a minute when I saw the question, and part of me wanted to answer lung and bronchus, and I realized that's because lung and bronchus fits into the category of the highest mortality rate in North Carolina. So if you're thinking about that, as some of our viewers were, that's why that may be in your head.
That is correct.
All right. So with that in mind, I'll turn this over to you and let you talk about the objectives for today's presentation.
Thank you. I'm going to steal this.
Absolutely.
Welcome, everyone. We're really excited about having this lecture series with you all. This is a second go-around for us, and we hope that you pick up out of this a lot of information that you can use in your oncology part of your assignments and your schoolwork. We've got several objectives today. They are going to kind of follow through the modalities that we use with breast cancer treatment. You can see these objectives for yourself there on the screen and with your PowerPoints that I think you have in front of you. Each of us, there are five of us here today, I can't count, who are going to talk about different modalities, and that's going to be from diagnosis to the end of treatment, active treatment. We're excited. Let's get going. Definition of breast cancer is, sorry.
Oh, that's okay. There you go.
Thank you. Sorry. Definition of breast cancer is very simple. It is a collection of cells that do not look like their originating cell, and they are categorized in a couple of different manners. One of which is non-malignant, and the other one is malignancy. Bet you didn't know that. The thing I want you to remember about breast cancer, we're going to have some vocabulary words going through here. We're going to be able to kind of talk you all through the way we deal with breast cancer in general. But what I want you to remember, maybe refer back to with this slide, is just the specific locations of these different cancers. So the incidence, who is getting cancer and how often, if you'll notice on this slide, this is a national slide. This is a national cancer, American Cancer slide, and the date on it, if you'll see, is 2016. What I want you to know is that in 2019, these numbers have not moved up or down too often or too much from what you're seeing here. In 2019, the estimated number of females who are going to be diagnosed with cancer is about 880,000 as opposed to 843. So that really doesn't, when you're talking about big numbers and little numbers, it's now about 30% for breast instead of the 29%. Cause of death in the United States ends up being about the same here as well. As Tim had mentioned earlier, lung and bronchus is actually the leading cause of cancer, death related to cancers. And you'll see here it's 14% for breast. And again, that number has only moved about 3%, so we're about 17%. And part of that, I think, is because as people age, as women age, we see a rise in some cancers, breast being one of them. So signs and symptoms of breast cancer. As everyone pretty much hears in October, it's the time that we examine and re-examine breast cancer in general. So you're going to hear things about checking, doing self-exams, self-breast exams, and some of the things that you're looking for are going to be the basic stuff. Changes in breast tissue. So you have to know what your own breast tissue feels like. Maybe if you've been going to a physician for a while, primary care doctor does all of your exam, he or she is going to know what those changes are as well. If there's ever any kind of nipple pain, skin irritation, discharge, those are things that should be a red flag, and having somebody check that out. Types of breast cancer, just like I said earlier, we have benign cancers and we have malignant cancers. The one I think that a lot of people are a little confused about is ductal carcinoma. We call that ductal carcinoma in situ. When it is a benign breast problem, it will be you'll always see the word invasive when you know that something is malignant. The so what of this particular slide is that you need to be familiar with the makeup of the breast itself, and I'll show you why here in just a second. So you see these ducts. Those are really important because that's where a lot of cancers are going to end up. Cancer can be anywhere where there is a cell that has reproduced too quickly. So all of this is important to know. This ductal carcinoma in situ, as I said, is the benign type of what people commonly refer to as a breast cancer. We really don't see it as a breast cancer. We see it as a precancerous situation. Still needs to be examined, still needs to be taken care of. And the thing that I want you to remember is that a ductal carcinoma in situ is going to be growing without tendrils. So when you look at these ducts, and you know that there are some cells that are quickly reproducing, those cells are going to multiply and stay on top of each other. So yes, there will be a lump. Yes, there is a reason to see a surgeon, etc., which Betsy Way is going to tell us here shortly. But it's different from the invasive component because the invasive component is going to have those little tendrils that are going to crawl and have the ability to go out into the rest of the body and form the malignancy. This is lobular carcinoma, which is another type of breast cancer. It also can be in situ, meaning at the site, and it can also be invasive. The difference between why we want to know is because the term lobular means that's where that breast cancer has formed in the breast tissue. One type of breast cancer that is alarming to us is the inflammatory breast cancer. As you can see here with this picture, the area that is red and inflamed, therefore inflammatory, is a very progressive, fast-growing, invasive cancer, and it needs a lot of attention up front. Oops, I'm sorry, I went backwards instead of forwards. So who actually is at risk for breast cancer? Those people who have some family heritage, and we'll talk about genetics in just a minute, but a strong family history of breast cancer is always a red flag. If, for example, you have a first-degree relative with breast cancer, such as a sister, a mother, a male member of the family, those are the people that we're going to look towards doing some imaging, some surveillance more frequently. Breast cancer can be caused by inherited gene mutations, and yes, there are some certain medications. For example, if you were a patient who had a pediatric pediatric cancer, some of the medications that were given to cure that cancer are probably going to be on the list for high surveillance. The piece about genetics in itself is another lecture that could go for a long amount of time, because we are really discovering some great things, some information about mutations. for example. But the thing that I want you to remember about genetics here is that we are looking for those mutations that we know are precursors for somebody having a high risk for breast cancer. Learning what those mutations are, and I'm talking about the BRCA1 and 2, the PI67s, are things that we're going to look at for down the road. The BRCAs 1 and 2 actually would indicate that the patient needs to consider a prophylactic mastectomy and oophorectomy, and his or her medicines are going to be treated around that. We've got screening options for breast cancer. I mentioned earlier a clinical breast exam is very important. It's usually done by a provider, but we do encourage women to know what their breasts feel like, and once a month, usually after a period has taken place, a menstrual cycle has taken place, then that patient or that person needs to do a self breast exam and report anything that's different, the lumps and the physical changes. Excuse me. The goal there is early detection. Our screening options begin with mammograms. After we have the breast exam, we encourage women to have an annual mammogram, and sometimes earlier. The average age is 40 that we suggest women start having an annual mammogram. Those will be screening mammograms until there is something of concern and the patient is diagnosed with breast cancer, and then those options will be a diagnostic mammogram. For those patients who have a history, a family history, strong personal history of breast cancer, or have been determined to have a BRCA1 or 2 mutation, we'll suggest an MRI. Some women have very dense breast tissue, and so a quote normal mammogram is not going to pick up some of these more posterior, small posterior masses. MRI is also often used in surgery, and again, Betsy Way is going to give you all kinds of information about surgical techniques. At diagnosis, diagnoses are usually determined through biopsies. It's something that, yes, the radiologist can look at and say, this one looks really suspicious, we need to, quote, put a needle in there. So what we're looking for are cells that do not look like original breast tissue. Again, surgical. I wanted to give you all some vocabulary words that you should know about breast cancer and the differences in some of these words. Staging, as you will hear in your oncology lectures, can be easily confused. We use staging for 2 different reasons. One, we need to know about that breast cancer itself. What stage is it? We'll see some slides here very shortly about stages 1 through 4, and you can look at those yourselves and determine why we would label them stage 1, 2, 3, and 4. But staging is also something that we use to determine whether there's a possibility that known breast cancer has escaped the breast tissue itself and is now setting up housing in some other part of the body. Phenotype is the type of breast cancer that is there. It's a specific characteristic of it. We're going to look at things that are ER, PR, HER2 new, if those which are receptors, and those are labeled or set up for you right there underneath the phenotype. But it depends, what that phenotype tells us depends on what kind of treatment this patient is going to get. Those phenotypes, the receptors, are what that breast cancer likes to have to grow. So if it is an ER positive breast cancer, the estrogen in the body is what is helping drive the growth of that particular breast cancer. Grade is going to be the degree to which the cancer cells look like the original. So breast cancer, and it's a grade 1. It's not too differentiated from the original tissue. 2 is going to be right in the middle, and 3 is going to be a more progressive type of cancer. We still use the tumor staging system, T for tumor, N for node, M for metastatic, and that is going to, you'll see that in a pathology report. That's going to give us the size of the tumor, whether there were nodes that were positive, and were there any metastatic cells found elsewhere. We look at lymph nodes, the N part of the TNM system. The lymph system is how this cancer spreads through the body. And I think one thing that's really important to understand here is that if for us to call somebody metastatic, that means that cancer has set up housekeeping elsewhere. But another thing that I want you to remember here too is that we will often have patients who have a positive lymph node. That does not mean they have metastatic disease, although we will talk about, we will discuss whether or not that lymph node has managed to let other cells through. I may want to revisit that. And we just talked about this staging. This is the process that we use to find out whether the cancer has spread. And so following the next couple of slides that are following are the ways that we do this. With staging, we can sometimes use a chest x-ray to see if we have any reason to have a more invasive or more intense type of staging. We'll use a CT scan and a bone scan. Those are the gold standards for any new diagnosis who might have a positive node or two or has given us reason to suspect that there is metastatic disease. I keep going backwards, sorry. We can also make use of a PET scan, which is a good combination of the two. And when we talk about PET scans, it is a different type of test, but more of a combined test for the CT and the bone scan. CT is going to look for soft tissue metastatic disease, and the bone scan, of course, the bones. Stages of the breast cancer, this has changed back in 2018, I believe, maybe 2017. And it is quite intense and confusing, so I broke it down for you. Stage 0, which is what we're going to refer to as that benign carcinoma in situ, and remember that's lobular or ductal. Stage 1 is what we refer to as early stage. So actually stage 1, 2, 3A, 3B, 3C are the curative stages for cancer. And the difference between all of these different stages is going to be in the number of nodes that are positive, the size of the tumor itself. And you'll see this in a subsequent set of slides. Stage 4 is the incurable stage. We know that there is metastatic disease that has set up housekeeping elsewhere, and so we have to treat accordingly. The big thing that most patients want to know is, what stage am I? Just exactly what's going on here and what stage. And as I said, I put in about 4 slides here for you to see and look at, notice the difference. And if you just very quickly, we'll slide through the rest of these here, but what you need to take note of is that this tumor, for example, is 2 centimeters or less, so it is still a stage 1. But then if the patient has more than 1 or even 1 lymph node, we change that category to a 1B, and that's, you can look at each one of these slides. You've got your little scale down here. This is a lime, and this is a peanut. And you can see the difference here and how that can affect what the medical oncologist as well as the surgeons and the radiation oncologists are going to look at. There's 3A, and here's stage 4. So the most the most popular areas that the breast cancer likes to go are going to be up in the brain, bone, lung, I forget one.
Liver.
And liver. See, I have friends here today. They're helping me. And it looks like we maybe ran.
Great. So we do have a poll question now. And thank you all for answering that first poll question. Which of the following statements about breast cancer screening and diagnosis is true? So if you think it's A, that would be a mammogram is a procedure that uses magnets, radio waves, and computers to make a series of pictures of the areas inside the body. B, an MRI, an X-ray of the breast is the most common screening test for breast cancer. C, when cancer spreads to another part of the body, it is called lymphoma. Or D, staging is a process used to find out whether the cancer has spread within the breast or to other parts of the body. So A, B, C, and D, you can go ahead and take your best guess, or if you're absolutely sure, just do that too. Again, this is anonymous. Amy, how would you do?
Well, it was a little concerning at first, but things are starting to look much better.
Great.
I think somebody finally got to the fourth answer, the fourth question.
Right, and we especially for folks who may have thought that it was B, what makes that D answer the definitive answer there?
So looking up at the question, and the key word here is screening and diagnosis.
Okay.
So one would actually think, so I can't say that this was a bad thing, one would actually think that we're asking about which modality, so to speak, would be the best to discover a breast cancer, but the reality is we're actually asking about the staging part of this.
Right.
So none of the above except for D.
Gotcha. And I guess we could distinguish too with B that an MRI
Is not an X-ray of
is
the
not
top
an
of the
X-ray.
breast.
It is imaging, but it's a different.
That
type
is
of
correct.
imaging from an X-ray.
That is correct. And because your lecturer didn't really distinguish between an MRI and an X-ray,
Well, there's only so much time. in
there's
this
only
discussion.
so much I can
All right.
say.
All right.
That is
Thank you.
correct. That is correct. So thank you. And are we finished and moving on here?
Are we, let's take a look. Let's see, our slide seems to be stuck there.
There we go.
Treatment
Okay.
options.
Nope, I'm sorry, y'all. Treatment options, which are actually gold standards for across the United States and in Europe. We have different modalities, and by modality, what I'm talking about is the type of treatment that patient can have. We use multidisciplinary treatments here, and we include surgery, medical oncology, systemic therapy with a chemotherapy, which is usually IV. We are moving into an area of targeted therapies and some oral therapies, which are wonderful, and you'll hear more about that from Emily Riddle. After the active treatment modalities of the surgery, the medical oncology, and the radiation oncology, ER-positive patients are going to be put on hormone therapy and will continue to be surveyed for some time. You'll get more information on each one of these as we go in. So the really important thing is we're going to move from this slight introduction into the different types of therapy. Keep in the back of your mind that anytime we have a patient who has been diagnosed with breast cancer, we have to take that patient as an individual, look at the comorbidities, look at lifestyles, look at all parts before we can make a really definitive decision on how that patient is going to be treated. And along with that, these characteristics are going to be very important when we consider the needs of that patient. So Betsy Blanton will be talking to you about some of that. So hang on to your questions. I'm more than happy to hang around and answer some questions, but I think right now we're going to go to Ms. Betsy Way.
All right.
Okay.
All right, Betsy, thank you so much for being here today.
Hi.
Hi. So let's see. Let me make sure our camera looks good. That's all adjusted. Betsy, you're a Greensboro native and a 2000 graduate of UNC Greensboro School of Nursing. Is that right? And you moved to Winston-Salem after graduation as a brand new mother to work as a new graduate at what was then Wake Forest Baptist Hospital in the neonatal intensive care unit. 10-year stay in Winston-Salem. With a focus on critical care, including surgical intensive care, and came to UNC after becoming interested in perioperative care following several years of working closely with surgical providers.
Right.
Great. Well, thank you so much for being here, and we'll go ahead and turn things over to you. Oh, and I did have, tell me, so what do you typically do when a patient comes to you for a visit?
Hi, thank you.
Mm-hmm.
Yes, so when a patient comes to visit us at UNC Hospital, they're going to be meeting with several providers.
Mm-hmm.
And it's very important before the surgical visit that we have a complete workup of the tumor. In doing this, the surgeon is going to be able to determine best surgical treatment options, and it's important for us to explain to the patient why they're coming in after having had a diagnosis of breast cancer and then having to come in and repeat the imaging. Several different imaging techniques are used to determine the full extent of the cancer. The first being the diagnostic mammogram, which has previously happened before the diagnosis, but it's going to happen again sometimes if we see other abnormalities, distortions in the breast, or possible additional calcifications. It is the standard after the screening mammogram before doing the biopsy. And when the patient comes in, the radiologist can take additional views with an immediate read for the patient. I wanted to throw in there that some patients will also have a 3D tomo diagnostic mammogram. Some of you have heard that a 3D tomo mammogram is the way to go these days. The conclusion is that with digital breast tomo, we'll find more of the invasive, harmful cancers, and it will save women the anxiety and cost of having additional screenings for what can turn out to be a false alarm. If a patient started out with a 3D tomo, they will then come in and have another 3D tomo for those additional views and workup. There always is the need for an ultrasound, and doing the diagnosis, the ultrasound is going to give a correlate with a mammogram. So if another biopsy is needed after the initial breast cancer diagnosis, we know that if the ultrasound and mammogram match up, that there's a good chance that if there's something there that's needs to be biopsied, we can do that. If there is discordance between the ultrasound and the mammogram, often the radiologist and surgeon and the whole comprehensive team would recommend an MRI. This MRI is going to be able to examine the full extent of the cancer and the disease in the breast, and tell us if another biopsy is needed before moving on. So you can see that after an initial diagnosis, there's still a lot of work to be done to pull together the treatment. I just wanted to talk briefly about the biopsy. With a biopsy, a patient is going to be in the mammography department with a radiologist, and based on the screening that was used and what they're able to visualize on screening, the patient will possibly have the core needle biopsy. With a core needle biopsy, the patient will receive the diagnosis, but it's not the complete definitive staging study for the diagnosis of breast cancer. A lot of times the patient, when they come in, they'll want to know, what stage do I have? From the biopsy and the imaging, there's a very good idea of the staging, but we do have to reassure them that after surgery, that is when the final staging report will come. Core needle biopsy is very important because during this time, the surgeon is able to start preparing the patient for surgery, and that's when the radiologist is going to place a geometric shape into the tumor. The shape can be ribbon or heart, barrel shape. There are a lot of different shapes. But in the radiology report, the radiologist will say the specific geometric shape and the exact location for it. And that's going to help direct the surgeon to the tumor during surgery. And a clip is placed that clip is titanium. It can stay in the breast indefinitely. Typically, that with surgery, the clip will be removed. After the clip is placed, then the patient will have another mammogram to determine that the clip is actually there. So when a patient comes in from an outside hospital, it's possible that they didn't have that post-clip mammogram, and we will need to redo that. Post-clip care, or for the biopsy, actually, it's the patient is going to have a small incision in the breast. The needle that is used to remove the tissue does make several passes through the tumor, so there are several sections that are examined, and that's how they're able to determine more of the extent of the disease. It takes about 3 to 5 days for that report to come back, and again, it's only a representation of the tumor. Sometimes there's more there that is not known until after the final pathology report comes back. It's not always possible, just like with imaging, to see everything that's in the breast. Because of that reason, there are different types of biopsies that we will do. One type is a stereotactic biopsy, which patients are never excited about having to do. We do a stereotactic biopsy to identify and sample calcifications that are there. There's not always with breast cancer a tumor, a measurable tumor, but sometimes there are calcifications that are there, and that is biopsied under stereo. Women will, or men will lay flat in the prone position. The breast is going through a hole on the table, and then the mammographer or radiologist is able to get a clear idea of where those calcifications are. Sometimes if we didn't get a good look on the mammo and ultrasound, an MRI-guided biopsy is needed, or surgical biopsy. The MRI-guided biopsy, patient goes into an MRI machine. The radiologist is coordinating with the MRI physician, doing, again, measurements and removing that tissue. Surgical biopsy is when we're not able to biopsy the patient in mammography, and actually the surgeon will take the patient to the OR. They'll receive light sedation and with the attempt to excise the entire margins for a definitive diagnosis. Is after that procedure that the patient might find they just have a benign mass there, nothing is needed for follow-up or actual planning for surgery and treatment of cancer. When there is the diagnosis of breast cancer and the patient comes in to meet with us, they often will walk in and they want to have it taken out and they want to be done with their treatment. It's our job to go through the surgical treatment options for the patient. We talk about local versus regional control. With local control, we're talking about removing the actual cancer from the breast. That breast is the local control, and that can be done with a lumpectomy or mastectomy. Lumpectomy has several different names. It can be, but it's a breast-conserving therapy, which is where we want to save the breast and remove the tumor, also known as a partial mastectomy, segmental mastectomy. Mastectomy, there are several different types, which we'll talk briefly about. The first is the total or simple mastectomy. Then you go into a skin-sparing or nipple-sparing mastectomy. Those are commonly used if the patient's going to be having a breast reconstruction later on. Then you go into the more historical types of mastectomy, but still sometimes use the modified radical or the radical, which in my 3.5 years of being here, I've not worked with a patient that's had a radical mastectomy, so not as common anymore, although every breast cancer patient used to have a radical mastectomy. So what is a lumpectomy? Lumpectomy is when only the tumor is removed with extra shaved margins around it. The goal of the lumpectomy is to remove all of the cancer that is there. There are definitely some criteria for a patient to qualify for having a lumpectomy, but it is something for many patients that we do try to encourage when having a very thorough conversation. Some of the things that the surgeon will talk about with a patient is, can they remove the entire tumor and still have a nice, acceptable cosmetic outcome for the patient? The surgeon needs to feel confident that that can happen, and the patient needs to be happy with that decision. And the other criteria is that the patient has to be agreeable to following up that lumpectomy with radiation. Radiation is a very time-consuming treatment modality that lasts anywhere from 4 to 6 weeks, 5 days a week. So we have to ensure that a patient is going to be willing to do that. You can see in the picture the incision site is very small, the breast lump is removed, and then the lump and surrounding tissue is removed. The clip is placed during the initial biopsy, but the clip that is there, the titanium clip that I referred to, is not visualized in the operating room. A lot of different reasons for that, but the main point is that we then have to take the patient back to mammography before the surgery so that they can have a localized procedure done with a savvy scout or the old-fashioned method of a wire. I'm going to speed up because I know I'm running out of time here. Savvy scout happens anytime before surgery. You can stay in indefinitely, and the wire is placed the day before or morning of surgery and is removed during surgery. With a lumpectomy, I included this little picture here because if you're interested in being an OR nurse, one of the things that you'll learn how to do is actually paint colors on the tumor that is removed. The painting of the colors is typically done by the OR nurse. It's a lot of fun, like paint by numbers. Oops, I'm not sure what's happening there.
Let me back that up. There you go.
Okay. And the reason for painting the tumor is so that there's communication between the surgeon and the pathologist about the orientation of the tumor within the tissue that's removed. The important thing about this is a patient after a lumpectomy is going to know, well, how do you know if we have all of the tumor out? If there's any cancer left there, when do we need to go back to surgery? And the famous saying is no tumor on ink. If there's no tumor on ink, then that is when we can move forward with the next step of treatment. If there's tumor on ink, then there's a discussion with the surgeon about whether we're going back for a re-excision or moving on to the next step in treatment. All right, so for mastectomy, candidates are basically almost anybody can be a candidate for a mastectomy. A lot of patients want to come in and have a mastectomy. One of the things that we're going to look at, though, is if the tumor is large, greater than 5 centimeters, and a small native breast, inflammatory breast cancer, radiation is contraindicated. They have a multifocal or widespread disease. And of course, for the emotional benefit and reassurance in an early stage breast cancer patient or a repeat positive margins after a lumpectomy with a re-excision. The total mastectomy, what we're going to be doing is removing the entire tumor, the entire breast, the skin over the breast, the nipple and areola complex, and the tail of Spence. What is not removed is the muscle and the lymph nodes. You can see a picture there, the outline of the breast, the tumor, and then those lymph nodes that would be removed. And then with skin sparing mastectomy, you actually need to have nipple sparing mastectomy up there. Skin sparing and nipple, again, is when a patient is going to consider having breast reconstruction. It's a really nice procedure for the patients because we can save the skin, which has more natural feeling, a more natural look. The skin of the breast tissue is soft and smooth compared to elsewhere on the body if reconstruction is going to happen. With a nipple sparing mastectomy, we're going to save the nipple, maybe the areola complex, and with a skin sparing mastectomy, we're going to remove that nipple but save the skin. There are some risks and benefits of that we will not go into right now, but this does lead into reconstruction. Then we have the modified radical mastectomy when you also are removing lymph nodes, and there is, with this procedure, a higher risk for lymphedema and some side effects. And then the radical mastectomy, which we rarely do anymore, but you're removing multiple lymph nodes going all the way up through level 1, 2, and 3. And the important part here is you're also removing the pectoralis muscle. And again, we rarely perform this because of more side effects related to it. So real quick on this slide, I just wanted to point out that through many trials, it's been found multiple randomized trials have demonstrated that breast-conserving therapy with a partial mastectomy and radiation provides survival that is equivalent to that seen with a mastectomy for patients with early-stage breast cancer. Major differences here between a lumpectomy and a mastectomy is that with a mastectomy you have a longer healing time. Patient will have a drain in place, the Jackson-Pratt drain. With a lumpectomy, they do not. With a lumpectomy, again, they have to have radiation and clear margins for it to be effective for treatment and to reduce the risk of breast cancer recurrence. Here we go.
All right. So another poll question. Of the following surgical methods of tumor removal, which one involves removing the tumor, entire breast, skin over breast, nipple, areola complex, and tail of Spence? And if you believe this is A, lumpectomy, or lumpectomy, put A, total mastectomy B, skin-sparing mastectomy C, modified radical mastectomy D, or radical mastectomy E. All right. How are they doing?
We're doing pretty good.
Good.
Yes.
All right.
Looks like total mastectomy. Yes, that is what we are, and the reason for that is because we're not removing any muscle with a total mastectomy, so it would not be a radical mastectomy. That's the difference. Thank you.
All right, well done for our audience. They're really paying attention here. All right, we'll move on to the next slide, and go ahead.
Oh, yes. Sorry about that. So then with regional management is when we get into talking about the lymph nodes. With the lymph node interrogation, the patient is going to be presented with the procedure of a sentinel lymph node biopsy, and then an axillary lymph node biopsy, which sometimes includes axillary reverse mapping. These are done in conjunction with the local management of the lumpectomy or mastectomy, and with a ductal carcinoma in situ, or invasive breast cancer, invasive ductal or invasive lobular. Ductal carcinoma in situ does not typically have lymph node interrogation because we know that cancer is not spread outside of the ducts. There's not a risk for it moving into the lymph nodes. With a caveat, if the patient is wanting to move forward with a mastectomy to treat the DCIS, we then at that point in time do have to do a sentinel lymph node biopsy, and the reason for that, which you will see the upcoming slide, is because you have to have breast tissue there in order to interrogate the lymph nodes. So if a patient with a DCIS, again, that final pathology report gives the final staging. If it comes back and the patient has upstaged from a DCIS to an invasive cancer, you then are, which occasionally does happen, unfortunately, then you're faced with having to interrogate the lymph nodes, and you are going to want that tumor present to be able to do that. So moving on.
Oh, we probably need to move
Sorry,
just so we can get to all of
Yep. Sorry about that. This could be a day-long presentation. So sentinel lymph nodes, that's what is removed in the sentinel lymph node biopsy. They are this lymph nodes that immediately catch any cancer that's coming from the tumor. We do this. The important part, what you need to know is that with a sentinel lymph node biopsy, a patient is going to have a little pre-surgical procedure. So many trips back to mammo, and there the patient is going to have a little radioactive tracer injected in the breast near the site of the tumor. The breast is going to pick up that radioactive tracer, send it down the pathway to those first lymph nodes that are going to drain the cancer. During surgery, when a patient is asleep under anesthesia, the surgeon is going to inject what we commonly call blue dye into the IV. That blue dye and tracer are going to pick up and color the sentinel lymph nodes blue. I've heard them termed blueberries. The surgeon can then take them out, send them to the pathologist, and when the patient comes back for a post-op appointment, we'll know more about staging of the cancer, because we'll know if there's cancer in the lymph nodes. This sentinel lymph node biopsy does reduce the risk for lymphedema. Common side effect is the urine will be green, because the blue dye and radioactive tracer through the lymphatic system are excreted through the kidneys, and the patient will, with any lymph node removal, experience a side effect of some numbness and pain. With that numbness and pain, we always provide reassurance. I'm going to skip over the axillary reverse mapping slide, because that is something that is a newer procedure, and just talk about the axillary lymph node dissection, which is when a patient who we know has a known breast cancer in the lymph nodes, the patient is at some point in time, whether it's before chemo or after neoadjuvant chemo, is going to have all of the axillary lymph nodes removed. It's common for 10 to 40 lymph nodes to be removed. This is a procedure that we're never excited to do on a patient, because there's a slightly increased risk for lymphedema. A patient will have a JP drain that they have to go home and monitor. And then again, more expensive sensations in the breast or arm, behind the arm, more commonly of numbness, which can be permanent, sometimes does resolve over time, and some always concerning for the patient signs of tingling, throbbing sensations, which sometimes the patient will need medical management for. Side effects of breast surgery, we're going to have a collection of fluid, whether it's serum causing a seroma, blood causing a hematoma, or lymphatic fluid leading to possible lymphedema. Lymphedema is a lifetime risk. It typically will present around 12 to 18 months after surgery. An abscess where infection has formed needs management by the surgeon with either antibiotics or to be removed and drained. We talked about the numbness and nerve pain. And then, of course, body image disturbances, which can lead to depression. Also, anesthesia can lead to side effects such as depression and post-mastectomy phantom pain. Just wanted to show you a picture of lymphedema here, the different staging. Lymphedema is treated by a certified lymphedema specialist, and we do have surgeries here that we're utilizing to reduce the risk of lymphedema. Actually, a clinical trial is underway here with one of our surgeons. The axillary reverse mapping, and here is a patient handout that we give all of our patients. The main point about lymphedema is how to reduce your risk and to prevent it. So if you'd like to know more about that, let us know. Thanks.
All right. Thank you so much. We really appreciate it. And we're going to move on to our next speaker. So Emily Riddle,
Yes, hi there.
welcome.
Thanks for
Thank
having
you
me.
so much for being here with us today. And you graduated from nursing school in 2008 at the
Yes, sir.
University of Tennessee and started in combo cardiac neuromedicine, 30-bed ICU, and fell in love with caring for post-op and cardiac crisis patients.
Yes.
Moved to breast medical oncology, and you spent the last 6 years there of your nursing career.
Yes, now longer career,
Great.
more of my career is nursing for breast oncology versus cardiac at this point.
All
Yeah.
right, and passionate about caring for and supporting the oncology patients. So thank you so
Yes.
much for being here today.
Okay.
You've got the mouse. We can
Yeah.
go ahead and move to your first slide.
So, hey everyone, I am going to talk about chemotherapy, the dreaded part that any patient does not want to hear about. They want to hear, because often in the breast cancer world we can go without chemotherapy. It's very dependent on the patient's situation. But if the patient does have to have chemotherapy, this is a systemic treatment, full body. We want to target not just cancer cells at a local breast or lymph node area. We want to make sure if there were any circulating cells that we are going after those. We can take those orally, we can take those intravenously. Patients get IVs, but most of them get central access through a port. Big things about chemotherapy. How does it work? So the short answer is that it kills rapidly dividing cells. And because it does this, it's good with killing cancer cells that rapidly divide. So the more rapidly it divides, probably the better chemotherapy will work for that cancer. But in addition, it affects things like, I'm getting ahead of myself here. It affects normal cells that we have, like hair, skin, nails, GI tract, and the bone marrow, which is the big thing that we check for with that. Chemotherapy is given in two.
Let's see, I can jump back here if you want. Is that right?
This is right. So 2 different time frames for chemotherapy. In the world of any kind of patient care, you could hear that a patient got neoadjuvant chemotherapy, which would be before they got surgery. In those patients, usually it's people with large tumors, known positive lymph nodes at the time of diagnosis, and highly proliferative tumors. Our biggest patient population there would be triple negative, where the estrogen, progesterone, and HER2 are all negative, like Amy talked about earlier, or in people with just HER2 positive disease, but estrogen and progesterone positive. We give this because we like to sometimes see the cancer shrink by measurement each week to know that it's working. So it's a nice way to know, like, hey, we're giving you this and we're measuring your tumor each time you come in because it's still there and it's getting smaller. And although hard to go through first, patients like that because they can see that it's working, and it kind of gives them more oomph to continue with the treatment. And then adjuvant would be after, and the reason we would do that is because we were on the fence if they needed chemotherapy or not based on the biology and stage of their tumor. So once they go to surgery and have it plucked out and the pathologist tells us, oh, we kind of found out it was a little bigger, it's a little bit more high risk, or we send an oncotype, which is a risk factor assessment that I think Leah will talk about, and it was high, so therefore an insurance policy for them is that we think they need a full systemic therapy, so we recommend that they get chemotherapy then. So I really just want to hit side effects with chemotherapy next, because if you're a ER nurse, a med-surg nurse, you might have a patient that is on chemotherapy, but in your care for different reasons, and they might be experiencing some of these major side effects. These are the major ones for breast cancer, but pretty standard all over. We know that patients with breast cancer chemotherapy are going to get some form of fatigue. It's the one thing we know they will have in some form. It can be very mild to pretty severe. A lot of distributing factors can, with how anemic they get and such. But they are going to have that in some form. It's a different thing than tired. It's a yucky tired. I like to tell my patients it's more than tired. I can't get up off the couch because I feel so tired to even walk over to the counter to get my mail, kind of thing sometimes. Nausea, vomiting, GI upset is a huge thing in the chemotherapy world, although we have gotten really better with the drugs that we use for that. The biggest thing, like we talked about before, chemotherapy affects rapidly dividing cells. So if you think about that, mucous membrane cells are super fast producing. They proliferate really quick. So does your skin, so do your nails. So you get the biggest areas with darkening of nails, a lot of GI upset with the nausea, stomach is burning, stomach is hurting. Sometimes people get some, like, even bleeding because their stomach lining gets so torn up from the chemotherapy. And then diarrhea. It's kind of all mouth sores, nausea, upset stomach, and diarrhea, which is a commercial, but it really does bode well in the chemotherapy world with how chemo can be bothersome on the GI tract. Alopecia is another one. Usually non-painful, although some patients do get a really sore head and complain that it's painful when their hair follicles start to release the hair. It's usually more of a cosmetic issue, and it's really hard, especially for the women that we mostly treat in breast cancer. Neuropathy is a big side effect in the breast cancer world. Chemotherapy, you'll hear of a term maybe Taxol or Taxotere, which is a taxane. They are hard on the nerve endings, and we get a lot of tingling in the hands and feet. And if you had a diabetic patient or somebody that was already predetermined to have higher risk of neuropathy, those people usually have even more risk to get it with chemotherapy. The last two things, one is heart failure. Some of our chemotherapies are hard on the heart pumping muscle. So the ejection fraction we tend to watch with echocardiograms. And then we already talked about mouse sores, so I'm going to go, I don't know how to work this.
Here, I can go, whoops, I can go ahead and advance that. There you go.
I'm not going to talk much about these. These are like newer things in addition to chemotherapy, more targeted treatments. You can read over this and look these up. The biggest kind of thing coming down the pipe with the PARP inhibitors are they are being researched in some of the BRCA1 and 2 mutation breast cancer patients that they might be helpful. They block DNA repair so that cancer cells could die, and they're using these in people with these really yucky BRCA mutation cancers. They've been in a lot of testing, and in other cancers as too, not just breast cancer. And then another targeted therapy that we see a ton of in breast cancer, here are a bunch of them, and this shows the pathways, but the one I'm going to focus on is the trastuzumab, which is Herceptin. This category has revolutionized, when I tell you revolutionized, I mean for real revolutionized the survival of the HER2 positive breast cancers that you saw back in Amy's slides. That diagnosis used to be a very, very bad one. Lots of recurrences, lots of people that became metastatic, and these target this HER2 protein on these cancers to block it from dividing and have really revolutionized these patients' care. The biggest thing with Herceptin and some of these other, the TDM1 that you see and pertuzumab, those are 3 big drugs we use for targeted therapies for HER2 breast cancer. They are the ones that have the reduced cardiac, that it can reduce your ejection fraction, and that's the big thing you want to remember about these drugs. So if you have a patient that are on these drugs and you're seeing them in the ED or on your med-surg unit and they have shortness of breath and feel like they're going to pass out, you might want to think about they might need an echocardiogram because they're having some heart failure issues. So that's kind of how I want to tie that back in. The last thing I want to talk about are biosimilars. These are drugs that they're very much like their original drug. So trastuzumab, there is a drug coming down the pipe that is this, and this is more kind of insurance driven as far as same type of drug, does the same thing, has the same side effects, but it's a tiny bit altered. But you know, United Healthcare wants us to use the biosimilar version of this drug. So you'll kind of see that in the cancer world as we continue. And I talked about the PARP inhibitor, which is my last slide here. Olaparib is the big one in the BRCA mutation world, like we talked about. And if you're unfamiliar with BRCA, it's the genetic predisposition. Angelina Jolie has it, and she had a prophylactic mastectomy, so you can kind of remember it that way. But this is the drug that they're using in breast cancer mostly for this as a PARP inhibitor. And it's proving itself effective in most things right now. So.
All right, Emily, thank you so much.
Yes, thank you for having me.
All right, and next up is Leah McDonald. So Leah, welcome. Thank you so much for being here.
Yeah.
So let's see, what do we know about you? You have a BSN and an RN, graduated from ECU in 2014, worked in oncology, both inpatient and outpatient, and then became a registered nurse, and enjoys the relationships that you enjoy the relationships you build with oncology patient population, being able to navigate them through our healthcare system, which can be a big job.
Yeah.
All right. Well, so glad to have you here.
Thank you.
And feel free to use the mouse, or I can move the slides forward.
Yeah, that'd be great. Thank you. All right, so the first thing we're going to talk about is radiation therapy, which a lot of our patients get the external type of radiation therapy. There's both external as well as internal. External is to the outside of the body. Internal is to the inside, directly near the cancer site. Like I said, we pretty much see external used for the breast cancer treatment. Some side effects that we see, there can be inflammation of the lung after radiation therapy, as well as arm lymphedema, which Betsy Way talked about earlier, and a higher risk of developing breast cancer in the other breast, which we don't see that a lot, but that is, it does increase your risk. Lymphedema, like we said, will refer to a therapist, a physical therapist that specializes in lymphedema therapy. And that's something that we do day in and day out, and that we can see, a year to 18 months after they've stopped their radiation therapy. Anti-hormone, anti-estrogen, estrogen blockers. This is something that a lot of our patients are started on if they're estrogen receptor or progesterone receptor positive. So it's a medication that's given to remove hormones or block their action, which stops cancer cells from growing. Here on the right, you can see the tamoxifen and the Femara. Those are two medications that are typically given. Femara is the brand name, letrozole is the generic name, and it is under a category called aromatase inhibitors. And tamoxifen is kind of in a category all on itself. And this is typically given to patients after they complete their radiation therapy, maybe a month or so after. And some people will even go on this as their primary source of treatment. We call that primary endocrine therapy. And they're usually on this for 5 to 10 years if they're on it after their radiation therapy. So aromatase inhibitors given to postmenopausal women that are estrogen receptor, progesterone receptor positive. I mentioned that before. They can also be given in the metastatic setting, so on stage 4s, but in combination with targeted therapy, things like Ibrance. You might have seen a commercial for that in the metastatic setting, and people do really well with that medication given in combination with something like letrozole, which is an aromatase inhibitor. Tamoxifen is given to patients with early localized breast cancer or in the metastatic breast cancer setting. Other aromatase inhibitors are anastrozole, exemestane, and letrozole, which I mentioned. They all have similar side effects, which I'll get to in a couple minutes, but some people respond better to one versus the other. So typically if we have a patient that comes in and they've been on letrozole, but they're having really bad joint discomfort, we might try them on Arimidex just to see if they do better on that. And it's just a lot of trials and tribulations to see what does someone tolerate more than the other. Some other things to touch on are Megace, which treats advanced stage hormone receptor positive breast cancers in women that aren't responding to tamoxifen. Megace we don't see used a lot, but a lot of our older population, maybe we'll put them on this because it can also help with stimulating appetite and energy levels. So that's something we do see, just not as often. Fulvestrant is used in the metastatic breast cancer setting. It's an injection. As you can see here, this is an example of what Faslodex looks like. Faslodex actually comes in 2 of those injectors. So 5 mLs of fluid in 2 different injections. And you can see the needle size, it's quite large, a large bore needle. So there's some positives to giving that medication. The positives would be fulvestrant. The medication's given in clinic, so you're 100% sure the patient's getting the medication, whereas an oral medication, they're taking it home, and there's some uncertainty of, oh, did they take it every single day since we last saw them, or did they skip a week when they were on vacation in Jamaica? There's all kinds of things that we look for with the oral medications. But a negative with this is obviously having to get 2 large bore injections, typically given 1 in each buttock, and it's 5 mLs of fluid, so it's a lot of medication to be getting in that big muscle. It is given intramuscularly. So some side effects for aromatase inhibitors and tamoxifen, they're pretty similar. Aromatase inhibitors, we see joint discomfort, hot flashes, vaginal dryness, osteoporosis, fatigue, weight gain, insomnia. Things that you typically think of when you see or when you hear of people being postmenopausal. That is a lot of what these symptoms are. Joint discomfort is definitely number one that we see, and that's typically a majority of our patients have that as a side effect. Tamoxifen, like I said, similar to aromatase inhibitors, tamoxifen increases the risk of a blood clot or a stroke. You can have bone pain, mood swings, loss of libido, and it also increases the risk of endometrial cancer. So when we're looking at a patient to say, should they go on one versus another, there's multiple things that we're going to be looking at to make sure that we're giving them the right medication. If they're already at an increased risk for blood clots, if they're already at an increased risk for endometrial cancer, maybe we're not going to be giving them tamoxifen. I think that's all I've got.
All right. So last poll question for today until the Q&A. Which method of treatment uses drugs or other substances that block the growth and spread of cancer by interfering with specific molecules that are involved in the growth, progression, and division of cancer cells? And if you believe that answer is chemotherapy, you'll put A, targeted therapies, B, radiation therapy, C, or anti-hormone therapy, D. So take just a few seconds, if you would, to go ahead and respond with what you believe is the correct answer to this question. So again, which method of treatment uses drugs or other substances that block the growth and spread of cancer by interfering with specific molecules that are involved in the growth, progression, and division of cancer cells? All right. Leah, how are they doing?
So this is actually a tricky question. The answer is targeted therapies, and that is because the targeted therapies are interfering with the growth and stopping the growth and blocking those molecules from being able to replicate. Chemotherapy is killing cells, killing all the good cells, the bad cells. So targeted therapies is the answer here, but it was a tricky one, so we'll give it to them that wasn't an easy
I see how
answer.
they could have gone after A, but really the distinguishing word there is growth.
Yes,
All right.
absolutely.
All right, thank you so much.
Thank you.
All right, and our final presenter today is Betsy Blanton. We have a small studio, so thanks for being patient with us while we all shuffle around here to get everyone here. Betsy, thank you so much for being here with us today. And let's see, we know that after graduating from UNC Greensboro, another UNCG graduate,
Yes.
we had the next 9 years were spent in 2 area hospitals caring for high-risk OB patients.
right.
Enjoyed leading the monthly OB tours for expectant parents, and became a mother and had the pleasure of working for the next 25 years with community general surgery in the surgical oncology office, and current position for the past 7 years serving as a nurse navigator for the breast oncology patients here. Great.
Correct.
Well, we're so glad to have you here, and I'll go ahead and progress that slide, and you're welcome to either have me progress the slides
I'll
or
let you
use
do
them
it.
as. All right, good enough.
I'll take you up on it. As all of us are nurse navigators, we are challenged with dealing with the health behaviors of our patients in regards to how health care and finances affect them. There are lots of visits involved in getting cancer care. It's not uncommon that some people that have transportation issues, they will end up skipping. Some of these behaviors they have learned culturally. Some of them are due to finances. Some of them are due to geographic locations. Our seasonal farm workers will have a grave problem with this, because for most people, if they don't work, they do not get an income. Other aspects are health-related outcomes. There is a higher stress level in the decision-making. Some people have feelings of anxiety, depression. They question the quality of life for all these treatments that we're recommending. And the other is financial. A definition I'd like to read is financial disparity is adverse economic consequences resulting from medical treatments. that's a very impactful definition. ONS has deemed financial disparity important enough that they have created a course on this. So I challenge you to go on the ONS website and look at this. So our job as navigators is to try to evaluate these folks when they come in, listen to them, call when they skip appointments, trying to get them in and try to connect with them with their care. We are blessed that we have 5 great outpatient social workers, and they do help us to deal with individuals who do not have insurance, who do have insurance with high copays. It is truly a team effort to help with these financial problems that people have. The other part that people have is the psychosocial. For various reasons, and when a person comes here, they just don't come with a diagnosis of cancer. They come with emotional needs that have taken place before the cancer. If there's any resolution or ongoing psychological, mental health issues, that may get worse, and we work with our Cancer Resource Center and our psychiatry department to try to assist the patient in getting them the support they need. Resources in the community are there in certain places. We do encourage people to go to their local areas if they can. A lot of times finances limit them because they do have to make that copay. So a lot of patients will choose to get all their care when they come here at the cancer hospital. The medicines that we give people and the elevated stress, a lot of people want people to come with them. If family members have to take off work, that means they're not getting paid possibly. There is the cost of transportation, wear and tear on cars. So sometimes people feel like they're taking advantage of a friend or relative or causing a problem for them. So that in itself, caretaker burnout is very, very real. So real that our Cancer Resource Center has developed classes for it to help encourage caretakers, teach them relaxation, how to take care of themselves so that they can help take care of this loved one with cancer, whether it be family or friends. We at UNC are blessed with a lot of hospital-based gifts and grants that we can connect the patient to. There are community resources that sometimes we don't connect with. That's church and social groups. And then with the state, the American Cancer Society this year has restructured their focus to where they are concentrating on transportation, getting the person to the facility, getting them to their treatments. And so we appreciate that to their need there. So this, let's see, go back to the one if you will. Let's see. This slide talks about, that's fine, this one's good. This was from a poll taken in 2017. We really need to have another poll of this because in the bar that says, I don't know, it is way too high. I would really hope and I really feel that with more navigators that we have now to take care of our cancer patients. They're getting into the rooms. They're getting to have conversations with the patients. We have the addition also of 5 outpatient social workers. We are learning more about the financial burden that our patients have. Some we cannot change. Some we work with the best we can. The patients as a whole are very appreciative for what we can do. Something simple like they have a phone, but they've run out of minutes. So the challenge is, how do we buy the card to get them more minutes on their phone? There is a solution. It just takes the patient to trust us enough that they will share that that is a need, and then for us to follow through with it and make sure that it happens. Part of discussing financial problems with a patient is based on trust. I've had patients who wouldn't tell me that they didn't have any food in the refrigerator. But once they realized that I wanted to help, but I couldn't help unless I knew what the need was, so that I could share it with the people that could make that happen. I think the other things that we need to do is to be a lot more observant. We need to listen to our patients. We need to make observations and not assumptions. We also need to listen to what their priorities are. They're not our priorities, they're their priorities. And they come with stories of other people's cancers. They come with expectations. And I think it's really important that we listen to those things to know what are correct and what we can do and what we can't do. So the nursing care for our patients. The body we encourage exercise. A lot of our cancer patients don't like that word. So exercise to us is 30 minutes of activity a day. I tell my ladies, you can walk to the mailbox, you can walk your dog, you can dance in your kitchen, you can hula hoop with your child. Just move your body. It does increase the blood flow, gets the oxygen circulated. The mind, there are mindful apps that you can put on your phone. There are yoga, which helps. There's mindfulness classes to help relax the mind, rest it. The spirit, their religion, their what they deem necessary for their inner calmness. Also, the family. If there's things going on within the family and the patient feels pulled between getting her cancer care and maybe her husband needs a pacemaker, then how do I keep with my cancer treatment and not let that fall by the wayside and take care of my husband also? The nursing care for cancer patients is very challenging. It is very complex, but it is the most rewarding, and I'm sure all of us will agree to that. All right, we have a case study. Now remember, you look at the facts, not make assumptions or inferences, all right? So this is the information that we're given. You have a 38-year-old single female. She has 2 elementary age children. She works full-time at a local grocery store. She takes online classes in business at the local community college. She lives with her elderly mother, who has early dementia, and has one brother who lives in Canada. She resides in public housing and relies on public transportation. She is diagnosed with stage 3, 5-centimeter breast mass. Well, she's diagnosed with a breast mass that's 5 centimeters. She has skin changes. She will follow the standard of care treatment guidelines. She attends church in her neighborhood. So the purpose of this case study is for you to look at the facts, see where there would be financial challenges, what is not mentioned, and what information you may need to learn. Also, how is the chemotherapy or the standard of care for this lady would be, Betsy, I'm going to defer to you, for a 5 centimeter stage 3. So it would probably be neoadjuvant.
Possibly a mastectomy.
Yeah. So it'd be neoadjuvant surgery and then maybe radiation with or without. So this is what this lady's looking at, which is probably going to take about a year. So where can we assist her with resources and assistance in this case study? So,
Transportation.
Okay.
She's got a transportation issue. She relies on public, she relies on public transportation. So that's something we want to make sure that she's able to get to and from her appointments for her treatment and for her follow-up.
so I see where she attends church. So since her brother lives in Canada, maybe there would be somebody in the church that could give her a ride.
Yep. And good support,
Yeah.
emotional support.
Yeah.
So if she lives in public housing, do we know whether she has some kind of insurance, or is she going to rely on her team to help her get charity care?
That is something we don't know. Usually you can't get into public housing is based on your income. So maybe she needs to meet with our social worker to see if she would be eligible for Medicaid. Medicaid would help with the problems of transportation also. It may help with the cost of her medicines.
What is she going to do about the care for her mother? I mean, so if she's got 2 school-aged children, there may be some help with that, with after-school care. But what are we going to do about that mom? Could that possibly be another social worker?
I was going to say social worker to see if-
Referral, because,
Yeah,
right,
to
someone's
see-
going to have to be there. And then what do we do if she has to have surgery that involves a mastectomy with a 4-week recovery period?
So we don't know her connection with the brother. We don't know if he would be able to come and help for a brief period. That is something we would have to ask her if that's possible. If she has a neighbor that could come and help for part of the day that lives near her.
What were the things on the slide before? And work at, with breast care, when you're going through treatment, you do have to take time off work usually for surgery recovery time, and making sure that she had everything situated at work that she needed. Things like FMLA and disability. We commonly fill out paperwork for those patients that are going to need time off to make sure their job is protected and that they're getting paid while they have time off to recover and go through their treatments.
Right.
So she works at a local grocery store. There's an amount of lifting that's involved in that. So that would be contraindication. I mean, that would be something that would be a conflict with her surgery.
Yeah, I would anticipate she's at higher risk for side effects such as seroma or lymphedema, where her time off work might need to be extended. So helping to educate her on if she has insurance or some type of cancer claim, which who knows, taking that extra time off work and trying to do everything we can for surgery to minimize her risk for those side effects.
And
Being proactive.
It could be, since she's a full-time worker also, that the grocery store would allow her to do another job
Right.
where it would be more desk work, but she still would get her hours in so she could get a paycheck.
Yeah, and she would have to be also, she would be around a lot of people, touching a lot of things, and if she's on chemotherapy, she could be neutropenic and have a higher instance of complications due to her job.
Correct.
Right. Well, just some of the things that would be considered, and I think this discussion here exemplifies that it really does take a village and a lot of points of view and different areas of expertise to contribute to this patient's care. All right. So in closing, I'm not sure who had the quote here.
We wanted to leave that in there for a remembrance that nobody out there is really truly alone, and there are many, many people, and it's really how you treat people in the end.
So as a nurse, we have the opportunity to heal the heart, mind, soul, and body of our patients, their families, and ourselves. They may not forget, they may forget your name, but they will never forget how you made them feel. That's from Maya Angelou. Thank you. We have references, and those are also on the PDF and on the recording. I'll put questions up, but we have gone a bit over time, so we're going to close things up at this point. I think what I'll recommend is that if you do have questions, please just email those to unccn@unc.edu, and we'll forward those on. We always want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Dr. Bill Wood and Mary King and Veneranda Obore and John Powell for all the hard work they do to make these lectures possible. Remember at the beginning I mentioned that feedback, that survey, unccn.org/eval/eval. Please fill that out. Let us know how we did, and we, again, really appreciate that. We need that feedback. Our next community college lecture is coming up in February 19th at noon, and that's Caring for the Patient with Lung Cancer with Dr. Charlotte, and she's newly joined UNC, and we're very excited to have her. And then one of our favorites, Jennifer Spring, will be here for Oncology Nutrition on March 18th, also at noon. We've recently, these are the self-paced online courses. We have Caring for the Patient with GI Cancer, Caring for the Patient with Head and Neck Cancer, Cancer Conversations coming up at the end of the month, Living with Breast Cancer. So if you want to find out more about this, Dr. Gallagher will be here on October 25th. And again, you can go to our website, unccn.org, to find out lots of information. And for you community college students, we have 12 different courses now that you can go and take, and you can receive those certificates of completion for those courses as well. So we definitely invite you to look at that and all of the different resources that are there. Call us up, email us with any questions. We're here to help with this. We hope that this has been informative to you. We thank you for taking the time to watch this, and we hope that you'll give some consideration as you develop your career to oncology. And as you can tell from the enthusiasm of our participants here, it's an extremely rewarding area to work in. So thank you all. Really appreciate you being here. Thank you to our audience, and until next time.
Thanks.
Thank you.